You just think to what one family did and what it has grown into.
It's very personal for just about everybody.
Realizing how much it has not only helped me, but other women is amazing.
The evolution of this race and the growth of it has been amazing.
Sandy Knight was my sister. She was a very kind, generous, very courageous person in her battle against breast cancer.
General Mills was a co-founder of this race with Sandy Knight being one of our great employees. Back then, you'd never know this thing became what it is right now.
I'd like to welcome all of you to the first annual Women's Race Against Breast Cancer.
The first race was held in the end of October of 1991, and Sandy passed away July 6th of 1991, so it was just 1 month after her 39th birthday. And so we just had a few short months to pull it all together.
None of us had run a race before, and it was a number of people came together. We just punted and we learned, and our biggest fear was nobody would show up.
We do have an accurate final total of number of participants. It's 1,115 people participating.
The first year, something like 1,000 people showed up, and it was awesome. It was amazing. It's like, wow, we can do this. And then as this thing grew and took the community with it, it just became a phenomenal event.
The uniqueness of the EFY fund is that the patient is able to use the fund at wherever they receive medical care. So it's not like they have to come specifically to Mercy. They can go to any of the providers in those 5 counties that we cover.
It takes resources to be able to continue to provide these services no matter where they are provided. We need to be able to continue to do that because, as we all know, there are still 39,000 plus individuals in this country that succumb to breast cancer every single year. We need to be here to ensure individuals have access to screening.
I found a lump and I came into the doctor and they said, yep, it's cancer. The Especially For You fund, I had known it was around, but I didn't know exactly what they did. When I went up to my doctor's office one day with a bill that my insurance wasn't covering, they said, you know what, you might want to go down and talk to the office. And so I applied for it, and they said, we'll just take care of the bill. And so I just cried. It was a relief.
My mom got diagnosed with breast cancer. She passed in June of '98, and that's when I first started doing it. And then ever since, I've done it with friends, family. It's just a very emotional part of my life. I look forward to coming down and doing the race. I was aware of Especially For You because I talked to my genetic counselor. She said that all of the coverage, the testing, I do MRIs now, and all of that is covered by Especially For You.
My sister and I started walking in 2005, and then some more of the family started in 2007. In 2011, my sister was diagnosed with stage 4 breast cancer. She lived almost 4 years with stage 4, but she walked the 3 miles every year after she had it. We never had a team until 15, and we just named it Team Deb, Live Life Till the End, which she did. The first year we had 78 people. Next year we had 164, then 177, and last year 209. So I think she'd be pretty proud of us.
The Especially For You race has been so successful over the years because of the community. Just looking at the community support through sponsorship, through volunteerism, through participation of having 15,000 people at the starting line, and the donations that we received, it really puts us in a position where we're able to be such a resource to individuals in need within this community.
I love the fact that this is grassroots. It's just been a great effort to make change, make positive change, and make good things happen.
The biggest challenge is deciding the color of the shirt. And we didn't always open it up for votes. So early on, we would find ourselves a little divided about which way to go.
We tried to find a color that we haven't had before, and after 30 years that gets to be a big challenge. I think we might have to start inventing new colors for that to take place again.
Who would imagine that you can have 15,000 people wearing the same color shirt, the camaraderie, and you see people that you haven't seen for a long time, you know, there's waves, there's hugs, there's tears. It's still an incredible event.
It started with a human being, Sandy and I. We know Sandy. People can relate to that one person inspired an event, and it's just grown from there. So we've never forgotten her legacy, and that legacy grows.
She would be so amazed and so proud of what the event has evolved into. I hope it goes another 30 years.
Wow. It chokes me up every time I see that.
What an amazing race and a great cause. And as I got ready for this presentation this morning, I put on my shirt, and my daughter has her shirt, and of course she wanted to wear it. And I just cannot wait till she's old enough so that I can teach her exactly what this race is about and how important it is and what a great cause it is.
I totally agree. So we want to just welcome everybody to this second EFY Health and Wellness Lunch and Learn. I'm Carol Birchenbreiter, and joining me today is Jen Somerville. It's race week, and the EFY office has been a flurry of activity getting ready for the 30th annual race against breast cancer. But like so many things this year, in 2020, the race is virtual. 3 years ago, I started the EFY Health Fair at the post-race activities. The EFY race is a great opportunity to get together with friends and family and to go for a run or a walk early in October on a Sunday morning. But as you can see from that video, it's so much more. The Especially for You race helps provide funding for local people for breast and gynecological cancer services. And the health fair was created to educate and increase breast cancer awareness. In the past, we've had representatives from local colleges, specialty vendors, health and wellness providers at the finish line at the race. Due to the pandemic, we're not able to hold the race in person this year. So as a result, Jen and I decided to embrace the times of this pandemic and to connect with our community in a virtual way. And so we're having these webinars, and we're talking about breast cancer wellness and prevention and screening and treatment. We believe that knowledge is power, and the more we can learn decreases fear and anxiety. So Jen, I just want to thank you so much for joining us again today. Jen is a nurse practitioner with the Hall Perrine Cancer Center, specifically with the surgery clinic, correct?
Yes. Yes.
So Jen, how are you doing?
I'm good. I am excited to be here on the eve of the Especially for You race. I think that video just personifies the race so well. I mean, I've watched it, I can't say how many times, and every time I well up. It is such a great cause, and I'm just so honored to be here to talk about screening and how we can save lives.
So Jen, I see you've got your EFY shirt on.
Yes.
And I do too. So do you have plans for a virtual race with your family or with your friends?
Yes, actually the surgical oncology office is going to have a special socially distanced outside walk that we're going to get together for in Solon, and then we're going to go out to brunch afterwards.
Well, how fun.
Yes, yeah.
Well, I reached out to my family. I registered all 13 of my local family members, as I do every year. So everyone's coming over. I did reach out to my daughters and said, does anybody have a pink tutu? Nobody does this year, but we'll survive without it. But maybe next year I'll order pink tutus for everyone.
Absolutely.
So as you can see, we are having a socially distanced conversation today, as well as when we plan to have our own race, we will be doing it in a socially distanced way as well. So, Jen, I have heard that between March and June of 2020, there was a 98% decrease in mammograms and other cancer screenings. And currently, there continues to be a 35 to 41% rate of delayed cancer screening. October is National Breast Cancer Awareness Month, and this year, due to the coronavirus and the reduction in elective screenings, it's even more important to bring awareness to this disease and ways to prevent and diagnose and treat breast cancer. According to the Centers for Disease Control, breast cancer is the second most common cancer among US women, with 42,000 was the study that I read, women dying each year. Early detection and treatment for breast cancer is vital for saving lives. The most effective tool for early detection is annual screening with mammography. Breast cancer is most treatable, as we know, when it is detected in its early stages.
Absolutely.
So today, Jen is going to bring to us some very interesting and helpful information about breast cancer screening and treatment. And I just want the audience to know that there is a chat feature on your Zoom meeting. So please, during the discussion, if you have questions, submit those questions to our live Zoom as they occur to you, and Jen will help us to answer some of those questions at the end. As you can see, we are on the stage of a large conference room at Mercy. There are only 3 of us in the room right now, but we are here because we want to know, Jen, what you can tell us about what we need to know about breast cancer screening and treatment.
Great. I am very excited to talk about this subject. I think it's such a pertinent time, as you mentioned. During the pandemic, there's so many people that have delayed screening because they're afraid of coming in. And I just want to say at the start of this that I think nowadays, more than ever, we kind of weigh our risk of going to the grocery store, of going to the mall to shop, and the risk of coming to the hospital to be screened for breast cancer, say get a mammogram. But the hospital, as I come to work every day, is a very safe place to come. Other than, say, the grocery store or the mall, everyone here is practicing the same measures. You're screened, whether you're an employee, a patient, we have restricted visitors. Anyone that comes in the building is screened according to CDC guidelines. We have everyone wearing masks, except as you explained for us.
Well, we were when we came into the room.
Exactly. And eye shields, facial coverings in patient areas, just to protect the eyes. And so here I feel most safe, even though it is a hospital where sick people come. The amount of protective equipment that we have and the protocols that we're all following, it's universal throughout this hospital. And so when I come to work, I feel like I don't have to weigh my risk of what I'm being exposed to. So this is a safe place to come, and I would encourage you, as we're going to talk about, to not delay your screening.
Well, I think you just can't say that enough, because I know that my friends and family, there have been times during this whole pandemic when I feel as though people thought I was a scary person because I worked at a hospital, and yet I agree with you. I'm so happy to know that the hospital is exercising really vigilance in being a really good place to come to continue to get our screening.
Yes. So as we said, we're going to talk about breast cancer screening and treatment. Let's talk a little bit about what the definition of screening is. It is a test that detects breast cancer, and screening entails testing for breast cancer before it becomes symptomatic. It's early detection. It identifies that breast cancer before we feel a lump, before we feel pain, before we think we might have anything going on. And that is how early stage breast cancer is diagnosed. We don't have symptoms when it's early stage, which we'll get into. If you detect it at an early stage, the prognosis is largely positive. that will not be the cause of your death. And I think breast cancer is such a scary diagnosis that it's very reassuring to know that you can detect it very early, and it's not a death sentence.
I agree. I think when you can't see it, you can't feel it, you don't really see any changes. Last time we talked, you said there are some physical changes that might occur, but even before that, mammography can detect the breast cancer.
Right.
So,
which is so amazing that we have this technology. So mammograms, as we said, are the main modality of screening. They look at breast tissue only. It's a low dose of radiation, lower than X-rays, and it's a 2 plates that compress the breast tissue, and it's not the most comfortable thing.
I can attest to that. I have had many mammograms in my life, and yes, it is something that we women, once we've had them, you remember, and you always talk about it, but still, it's not painful, but it's not a walk in the park. It's not something maybe I would want to do every day.
Yes.
But it's not terrible.
Something that I have yet to experience. I know I will at a later date, but that allows better visualization of the breast tissue. So the ultimate squish is meaningful. It is needed. But what a mammogram does is it alerts the radiologist who's looking at it to different calcifications or masses. Calcifications appear white on a mammogram. And before we get on to this next slide, calcifications are like little tiny dots on that screen. And breast tissue, so the breast tissue is made out of ducts and lobules, which is the dense part of the breast tissue. And the rest of the breast tissue is fatty tissue or adipose tissue. If a woman has more fatty breast tissue, there's less white in that mammogram picture. So it's easy to tell those little calcifications that can be detected, and they're called DCIS, or ductal carcinoma in situ, which is the earliest stage of breast cancer. However, if you have dense breasts, which I'm sure some of us have been told, I think my mom is definitely one of them that usually has to go on for an ultrasound due to the density of her breast, but dense breast means that you have less fatty tissue and more ducts and lobules within your breasts. The way that breast cancer starts is it grows in your ducts, which are the avenue that milk is delivered out the nipple for breastfeeding. So breast cancer grows in that, and when it becomes, instead of in situ, inside the duct, the carcinoma becomes invasive, and it invades the breast tissue outside of that tube or that duct. But the calcifications on a dense breast tissue in a mammogram look like trying to find a snowflake in a blizzard. And so that's why, based on specialty recommendation, if a woman's breasts are too dense to really be able to see that snowflake in the snowstorm, you do end up having a recommendation of going on for ultrasound, which we'll talk about. But basic screening for a mammogram, if Carol, if you're just going in for your yearly, you get what's called a screening mammogram or a 2D mammogram that we talked about. It's between 2 plates, and there's 2 views of your breast that are taken, and they look at that and see if there's any suspicious areas. Then there is something called a 3D mammogram or a diagnostic mammogram. That is performed if a woman has symptoms, so if she feels a lump or a change in her breast, or if there's something suspicious on that 2D mammogram and they recommend doing a 3D mammogram. So what exactly is a 3D mammogram? There's a couple different names: breast tomosynthesis, there's digital breast tomosynthesis, all the same thing. Mercy actually happens to have that technology here, along with many other centers, but that is something where your breast is still compressed between 2 plates. It's still a low dose X-ray, but there's actually an arc that the X-ray goes around your breast to allow for a 3D image or several different images of that breast tissue. So you get a more detailed view. And I think a common question you may be thinking is, well, how come everybody doesn't just get a 3D mammogram? Carol, I can read your mind. It's overly sensitive to the point that we don't necessarily need that sensitivity unless we have a suspicion or symptoms. So it's really based on the radiologist and the breast specialist to refer on and say, listen, we actually do need to do a 3D mammogram. 2D mammograms, the screening mammograms, are extremely sensitive as well. And we have a well-developed protocol for whether or not to do additional screening in addition to that screening mammogram.
So you were mentioning dense breast tissue, which I've heard a lot about, but up until very recently when I did some research for our discussion, I really didn't understand that. So is there anything that a woman can do in order to decrease the density of their breast tissue? I know last time we talked about the microenvironment, which I love that topic so much. In fact, I brought you some green tea today because I just wanted to help you increase your microenvironment. But back to the question.
Thank you.
I just wondered, what is it? Is the dense breast tissue something that I can change, or is it something that just is the way it is?
It really just is the way it is. As I said, I think, say if your mother has breast tissue, dense breast tissue, as my mom does, I think I most likely have dense breast tissue. And dense breast tissue, as I said, you have more ducts and lobules, and breast cancer develops first in the ducts. So you're more susceptible because you have more of the tissue that has the propensity to develop breast cancer in. But as far as changing it, there's not really much you can do to change it. What you can do is you alluded to is change your microenvironment by eating well, physical activity, weight reduction, those types of things. Drinking green tea, I'm so glad, thank you. So there's many different organizations that recommend, that have guidelines based on mammography screening. How often, what age to start, what age to stop. And you could go online right now as we're talking and find different numbers than what I'm providing you. And the reason is there's at least 10 organizations that have different guidelines. Those guidelines are all based on research on outcomes as far as prognosis with early detection, but it's also based on some of the harms that have come to light now that we have been screening breast cancer pretty regularly for a good 20 to 30 years. And those are false positives. And a false positive comes about if there's an area of suspicion on your mammogram, you get a call back, which can be very distressing. That doesn't always mean you have cancer, but they want to look more closely. So they order a diagnostic or a 3D mammogram or an ultrasound, and then they say, oh, it still looks suspicious, let's do a biopsy. That biopsy comes back negative, meaning there's no cancer, but gosh, that was a false positive. A lot of emotional distress and pain, and just the breast is a tender area to be manipulating. So that's a false positive definition, and that's one of the things that has brought about some of the differences between different organizations as far as recommendations. The other is overtreatment. Overtreatment especially refers to DCIS, or ductal carcinoma in situ, that earliest stage of breast cancer. The standard of treatment is to remove it through surgery, which we'll talk about. But there are some types of DCIS that will not develop into invasive breast cancer and eventually cause death. However, despite the technology that we have today, we don't have the ability to differentiate between DCIS that will develop into invasive breast cancer and DCIS that will stay the same throughout your lifetime.
Very complicated issue.
Yes, and so therein lies the reason for all of the difference in recommendations as far as mammography screening. So let's get into this a little bit, and now that you have a background of the reason why some of these things differ. So women with an average risk of breast cancer diagnosis should begin regular mammography screening at age 45. Women should be given the choice to begin breast screening at age 40. So let me go through these and then we'll talk about it. So women aged 45 to 54 should have annual mammography screening. And then age 55 and older every 2 years, but should still be given the choice for yearly mammography. And then women over the age of, 70 and older, mammography has been shown to benefit if they have, if they're overall healthy, and if they have a life expectancy of 10 years or longer. Obviously, they still have the choice to continue with annual or biennial or every 2-year screening as well. So there's, as you can tell, a lot of choice involved in this. And so there's a couple different percentage numbers that help explain why there's different ages and different recommendations just in that 40 to 59-year-old age range. So the first 5 years of the 40 to 44, you have an 18% decrease in mortality with regular screening mammography. In the age group of 45 to 49, you have a 29% decrease in mortality. So mammography screening at a regular rate provides a greater decrease in mortality. It has a higher benefit. It's been shown over a population of women. So that provides a little bit of insight also as to why there's a difference for women ages 45 to 54 to have annual mammography. And biennial mammography screening, that, or every 2 years, after the age of 55, that is something that you really have to talk really with beginning mammography screening at the age of 40. You really have to have a good informed conversation with your primary care provider and talk about the risk of false positives, the risk of overtreatment. Does that risk outweigh the benefit of being screened and identifying early breast cancer for you? And we talk about average risk. What does that mean? We talked about that a little bit with the prevention presentation, but average risk means you don't have a family or personal history of breast cancer. You have not had radiation to your chest from the ages of 10 to 30, and that you don't have any genetic predispositions. So the BRCA or the BRCA gene mutation is one of the most common genetic mutations that can lead to breast cancer, but there's many others. If you don't have any of those factors, then I would say at age 40, it's a good thing to talk with your primary care provider about, hey, do I wait 5 years or do I start now as far as screening? You can talk about, the risk benefits. How do you deal with these things as a person? Are you someone that would worry and about maybe a suspicious finding on a mammography and want to just get it checked out? Or are you somebody that says, let's just wait and see, we'll do screening in 5 years from now?
I think it's so important to have those conversations because it is really complicated. And I think as a consumer and as a woman, I don't always know, as a person, I don't always know what my doctor knows, what I need to be able to ask those questions. When you say no radiation to my chest, does that mean when I was a teenager and I was sunbathing in my bikini, that sort of radiation, is that what we're talking about?
No, and not the occasional chest x-ray or MRI for something completely different. It's radiation treatment. But gosh, if it was because we were sunbathing in our bikinis, I think all of us would be high risk. So thank goodness that is not the case. But yeah, I think you bring up a really good point. It's important for us to have that discussion with our primary care provider to say, you know, this is my personality. This is, I tend to, you know, be more conscientious about this stuff or worry a little bit more about this stuff. And so I do want to do the annual screening, or that might cause me more anxiety than needed. And given your history, and they can do a thorough history with you, they can say that recommendation makes sense. Carol, you know, let's not start, or Jen, let's not start screening until 45. You're low risk. That makes sense. However, say you come in and say, I don't want to start screening until 45, and the doctor says, well, actually, you have a family history of breast cancer, you have a genetic mutation, or, you know, look at this trend in your family, I think it would be a good idea for us to start screening. So it really is that dialogue between you and the provider. And I think some women are as you brought up, that's a big choice for me to decide whether or not I should begin screening. This allows me a lot of choice. But I think it's also the provider's prerogative to kind of provide that expertise after having that conversation, knowing that you're well informed, to say, you know, I'm looking at this from an objective view. I know you, and I think this would be the best for you. But let's continue here. As I talked about, it does raise a lot of questions, and you may come upon the American Academy of Family Physicians or the U.S. Preventive Services Task Force organization's recommendations, and those could be, they are different, slightly different from what I'm telling you. And that I would say is that the medical field has come far in that aspect, knowing that each individual doesn't fit into one box. Each of us is different as far as emotional, mental, spiritual, and physical. The patient knows their body and their mind the best. The provider knows the information and the background to help guide you the best. And so working together in that, I think, helps to individualize healthcare in a way that we have not before. So this choice is really an advancement for women and screening.
No, I really appreciate that opportunity to collaborate with my provider and to have something to say about my own health and my choices in how am I going to deal with those risks. If they make a recommendation, we can have a discussion about it. You know, the internet is so available to all of us nowadays. And I know I was doing some research for our discussion, and there's a lot out there, and it is confusing. And so I think it raises a lot of good questions, but it might make me worry too. Oh my goodness, here I am, you know, at my age, and maybe I didn't, you know, advise my family or my friends or myself to do things at the right age. And so I think it's just, it's really important to, if you have questions, take them to your provider. And don't get all of my information off the internet.
Right, right. Well, and I think the biggest takeaway from this, instead of having to remember, you know, between the ages of 40 and 44, this is what I should be doing, just know that at age 40, you should be having a discussion about mammography screening and go from there. So a lot of us, I think, have heard about ultrasound and MRI for breast screening as well. They're both used for further imaging breast tissue. As we saw in that video, the daughter of a breast cancer patient that has since passed away does regular screening with MRI. She is high risk. She has a family history. But ultrasound and MRI are not recommended for just baseline screening. They're too sensitive. They would result in what we've talked about, too many false positives, too much over treatment. And so the benefit doesn't necessarily outweigh the risk in that aspect. They are very useful and highly sensitive for when you've followed with a breast specialist, such as a surgeon or a medical oncologist, that says, listen, you've been referred to me. I can look at this picture and I think we need to do some further exploration. By no means, as we talked about before, if you get a call back from a screening mammogram that says, you know, we need to do further screening, does that mean that you have cancer? It is always distressing, but I think knowing this knowledge that our technology is so good that the possibility of a false positive, although low, is there, is important knowledge. So percentage of false positive findings leading to a biopsy is 7% with annual screening, 4.8% with biennial or every 2 years screening over a period of 10 years. And so this just provides us with a little bit of insight as to, at a certain age group, do we go to biennial screening or do we continue with annual? And you have kind of some concrete evidence. There's about a 2 to 3% difference in false positives. And so do you look at that 2 to 3% and say, this is something that I'm not willing to risk, I don't want to do annual screening, or is it 2 to 3% isn't a big deal to me and I would like to do annual screening for the benefit that it provides me in detecting early breast cancer? But that's, I think, a helpful number for women to see and know that that's part of what goes into these recommendations.
Yeah, I think that simplifies some of these recommendation differences a little bit more. And so thanks for that explanation.
Yes, so we are going to get into treatment of breast cancer. There's 4 different modalities of treatment of breast cancer. Surgery is usually the first modality to remove the cancer. There are some circumstances in more aggressive cancers where chemotherapy is preferred first, but that really depends on a specialist consultation and what you decide is best, what they decide. But there's also, chemotherapy, and then there's radiation therapy, and there's also hormonal therapy. So there's a couple different types of breast cancer. Any breast cancer that we detect, we would do a biopsy and we would test it for certain receptors. Hormonal receptors such as estrogen receptors and progesterone receptors, and then another receptor called HER2/neu receptor. Most breast cancers are hormone receptor positive, which would mean they would have hormonal therapy at the end of the rest of their treatment, which is usually taking a daily pill for about 5 years, and that reduces the recurrence of breast cancer. Radiation is usually done after a lumpectomy, and a lumpectomy versus a mastectomy for surgical treatment is based on the characteristic of the cancer and the size of the cancer, also the size of the breast. To simplify it, if there's a cancer that is sort of widespread throughout the breast, it doesn't make sense to take a large lump and have a poor cosmetic outcome with one breast being smaller than the other. It makes more sense to have a mastectomy. There is a choice. There's certain nuances that go into this choice, but between choosing a lumpectomy, that usually women go on to receive radiation after they have a lumpectomy, or a mastectomy when women usually do not have to have radiation after a mastectomy. Again, there are nuances where that can be different. And then with each cancer, whether it is a mastectomy or a lumpectomy, there is something called a sentinel lymph node biopsy that we do. That we'll talk about that a little bit more in the latter part of this presentation, but basically we take out the main lymph node that drains the breast, and that is most likely for tumor cells to be found in that lymph node. So one of the things that we do for mastectomy patients here is what's called a PEC block. And it is an an anesthetic similar to lidocaine that is injected, you can see in this picture, in between your pectoralis major muscle and your pectoralis minor muscle. So on the, I guess I'm looking at it differently, but the left, or how about the right side of this person here has that pectoralis major muscle, and the left side of the person, you can see that tiny little muscle is the pectoralis minor muscle. In between there is your nerves that innervate or that give feeling to and function to the breast tissue, your chest area. So the anesthetic bathes the breast tissue and numbs that area to help with pain control during and after surgery. So it's been shown that this leads to increased functional movement, decreased use of morphine after surgery, which is huge. There's mastectomy patients that we do here always spend the night afterwards. And I can't tell you the amount of women that after I see them in the morning before they go home say, oh my gosh, I can't believe how great this went. I only took Tylenol last night for pain. I'm feeling great. The PEC block does a great job with managing their pain. They're able to move around a little bit more and accelerates the healing process. So that's a huge aspect of the surgery that has been so beneficial for so many patients.
You know, I think if I were looking towards having surgery like that, it would be so comforting to know that the doctor was giving me something that would relieve the pain before the pain is that before I wake up and I'm actually in pain, and that I think just demonstrates so much care to me as a patient that, and it would also increase my ability to move, but would reduce the amount of constipation I might have afterwards, because pain medications absolutely always do that. And so it's really, I love having that information to know that this is available, that this is something that the doctors can use.
Yeah, it's something that the anesthesiologist would do right before surgery. They give you a little medicine to decrease your anxiety, and then they use a needle to just kind of insert in that area, and they use ultrasound to make sure they know exactly where they're going, and it's been very successful for patients. So with a lumpectomy procedure that we talked about a little bit, you take a lump of tissue, you localize that tissue during surgery, and you take a lump of tissue that has the tumor contained in it. However, if you don't have a way of testing those margins or the edges of that lump for cancerous cells, there's a high risk of having to go back into surgery or of re-excision and removing further tissue to make sure that it's completely out. So there's something that we use during our surgery, and there's a picture of it here. That is a margin probe, and it actually is a tissue analyzer of the lump of tissue that we take out. I apologize for kind of the gross description here, but real time that it demonstrates it analyzes the tissue and then says whether it's positive or negative for cancerous cells. If it's positive, then we take a little bit more tissue. This reduces the amount of tissue we take, because we can take a smaller amount and then test the outside of it and take just those margins. But it also allows us to be very confident that most of the time we have gotten what needs to be taken out. So re-excision rates usually are 16% nationwide. With the use of the margin probe, it's 6%. So that's a huge percentage difference, and I think that's a big confidence builder for patients, for the surgeon. I can tell you almost every lumpectomy that we do, we end up taking a few margins based on the analysis of the margin probe.
You know, a few years ago when we started the health fair after the race, I contacted the margin probe representative, and he brought a margin probe monitor and the probe, and he had this piece of plastic that looked like tissue, but it wasn't, thankfully, actually a lump.
Oh, good. I'm glad it wasn't real.
Yeah, I was too. But he demonstrated how they use the margin probe in order to just make sure that the margins are clean. And I was just so impressed. I thought, what a great technology to set your mind at ease that maybe I won't have to go in for a second surgery right away, because the first surgery is enough wear and tear on my body, and to have to go in for another surgery because the margins weren't clean would just even be more difficult. And so I was really excited to get that information and to see how that actually worked. And it was really cool to see just the way it works with the representative from the company.
Yeah, it's enlightening to see it in action, and also it's such a great piece of technology that really affords the patient and the surgeon a great deal of confidence. So, so I talked a little bit about localization of cancer during a lumpectomy. So how do we know exactly where to go? Where is that tumor in the breast tissue? Yes, we map it out on previous scans, but when you're actually looking at the breast during surgery, how do you know exactly where to go? So there's something that we use here to localize the tumor, and it's called a Savvy Scout. It's a little reflector. It's up here on the screen. It's about the size of a grain of rice. It's compared kind of to a dime here, but much smaller. And that is inserted a few days before surgery into the actual tumor tissue. And it's radiologist guided. They look at the tumor and make sure that they know exactly radiographically where it's at, and then they insert that Savvy Scout. This is a really good way for us to minimize the amount of tissue that we take. How did we do this before we did Savvy Scout? There's something called needle localization, and it's right before surgery where you actually have a wire inserted down into the tumor, and it comes out of your skin, out of your breast. And I have seen women with this, and it's often very uncomfortable. They don't know how to move or where to place their gown, and it ends up being sort of an inconvenience, because not only for the patient, but during the surgery, that wire doesn't necessarily come out at the area that is closest to the skin from the tumor. And so sometimes the surgeon ends up having to take extra breast tissue to go in at that level of that wire. You have to go in at that level of the wire. Whereas using the Savvy Scout, it's a radar, and you can tell how deep, based on the radar sound, how deep it is in different areas from the skin. And so you can choose, based on cosmesis and wanting to take as little tissue as possible, exactly where to make that incision. And so Dr. Reed is really able to localize the tumor in a way that favors cosmesis and not taking too much tissue. So this is a really important piece of technology, and it's nice because that woman doesn't have to come back in procedure prep with that wire kind of sticking out and not knowing. And it's a very convenient way for it to be done, and it's a very precise tool.
You know, it's wonderful to know that we have that kind of technology available to make the localization of the tumor a little bit better and more specific for the doctor. And, you know, I mean, as a woman, I would like it if they took as little tissue as they needed to. And and I understand that sometimes these new technologies cost a little bit more, but there's where the EFY fund really does come in to help pay for some of those things that really maybe your insurance doesn't cover.
Yes, well, and I think just in general, you know, we think, oh, these great technologies, this must be very costly, I probably can't afford it. And I think, as you said, I think it's really important for women to know that not necessarily is that true, but also if you don't have appropriate insurance coverage or can't afford it, the Especially For You Fund is a great resource for women. So there is also another way that we identify the node within the axillary tissue. So the nodes in our axillary tissue or our armpit are what drain the breast tissue. And there's always one main node that drains that breast tissue. And the way that we localize that node is just prior to surgery, there's something called lymphoseek that we inject, that is injected into the breast just around the areola. And that enters the lymphatic vasculature, the vessels, and finds that sentinel node, or that main node that drains the breast and is the one that will be draining any tumor cells that have spread. And so instead of having to take several nodes, as was done in previous times, we end up just taking one, and it's tested real time during surgery. If that node does happen to have cancerous cells, there's times that we will take more lymph nodes. But this is a really good way for us to be sure that we are getting the correct node that is the main drainer of that breast tissue. So these are just some of the technologies that we use, and it's a great way to treat breast cancer and put people at ease with such a high anxiety topic.
Well, thank you so much for sharing all of that, because it really does, I really do believe that knowledge is power, and that the more we can learn about our bodies and about any diagnoses that we have, the more informed we're going to be about making good decisions with our healthcare provider as well. So thank you so much for sharing that with us. So
thank you.
We do want to share our polling question with the audience right now. And so the polling question for today is, how likely are you to schedule your breast cancer screening and or wellness screening that you might have been putting off as a result of attending this webinar today? Or if you're caught up, how likely are you to encourage a friend or a loved one to go in for that screening that they might have delayed? So if you could now answer your polling question, and we will definitely get back to those answers in a little bit. Jen, I just wanted to check and see if we have any questions that have come in on our chat.
All right.
So let me just take a look.
So while you're doing that, I just want to make clear that overall screening is a life-saving modality, and that yes, there are always harms to anything, and we did talk about those, but it's very important to have that discussion with your primary care provider about how often to do screening and when to start. But screening saves lives.
Well, you know, I love it to just know that. So, you know, that there's always that research being done, but yes, that is so important. So just a couple of questions that have come in. One thing I wanted to know, one thing one of our viewers wanted to know is, nobody in my family has had breast cancer. There's no history of hereditary breast cancer. And so how likely, why would I need to go in and to have this screening? Why would I need to put myself through that? Is that something I should do?
So first I would start out by saying that a hereditary or genetic cause of breast cancer only accounts for 10% of diagnosed breast cancers. So that's quite low. But there's also, you have to look at the family history. Aside from just breast cancer, there's other cancers that can increase a woman's risk of developing breast cancer, and those include colon cancer, prostate cancer. So say you have mostly a family of males. Those are cancers that can be hidden in males that, again, put a woman at higher risk for development of breast cancer. So it's just important to know your family history and cancer history well, but I also think knowing that 90% of cancer is really not hereditary or genetically related puts a big burden. There's a lot of different environmental factors that lead into development of breast cancer as well as other cancers. We talked a lot about the microenvironment in the previous presentation, and diet, exercise, weight reduction are all really good modalities to help prevent it, but there's a multitude of foods that we eat, environmental exposures that increase our risk. So I would say regardless of your family history, you're still at average risk. And as we discussed before, 1 in 8 women over the course of their lifetime will develop breast cancer in the US. So therein lies the reason to still get screened even if you don't have a family history.
Absolutely. So we did talk a little bit about men having some risk of having breast cancer as well. Men don't get mammograms, so how do they get screened or diagnosed?
So for male breast cancer, it is rare. However, it does happen. Men do have breast tissue, and it's usually diagnosed through there's symptoms, but it's so rare that there's not a recommendation for regular screening for breast cancer for men. But it's usually diagnosed through an ultrasound or other modality, and we would treat it the same way that we treat breast cancer for women. But it is important to be aware of that, and being a male in a family that does have a high family history of breast cancer, it's important for that male to be aware that there is a small possibility that could develop in him as well. So having that conversation with their primary care provider about what to look for and that kind of thing is important.
Well, thank you for answering those questions. And we did want to just check and see if we have any responses to our polling question. Can't see it. All right. So the majority of people said 100% they would definitely go in for their screening or encourage a friend or family member to go in and have their screening as well. So that you've convinced me and you've convinced our audience to go ahead and go in and get screened.
That's excellent. I think, especially in this day and age, as we talked during the pandemic, there is a lot of screening that is not being done, and it's that much more important to have that screening and do that early detection, so that 10 years down the road we make sure we're preventing those deaths. So this is a big deal, and I'm glad we were able to get this out to people today.
I am too. So since EFY began 30 years ago, it's grown to be one of the largest community-supported events in the area. Every year we see close to 15,000 people who come out for the EFY race. And this year, with 30th annual EFY race being virtual, we still have over 10,000 people who have registered for the race. So I think that is a tribute to our community and to EFY as a whole, because as we saw in the video earlier, the EFY Fund has supported more than 11,000 individuals over the last 30 years and given them access to 24,000 services. So without our sponsors, Mercy Medical Center, General Mills, and all of our sponsors throughout the community, we couldn't do this work unless we had that support of our community and our sponsors. So it's not too late to register for the race. Go to Especially For You website and you can get more details. Please submit any topics that you might have for future webinars. Jen and I do plan on doing another one of these in the future, and so watch the EFY site because we will definitely be advertising it there. Jen, I just wanted to thank you so much again for preparing all of this information for us and for being here to share it with our audience and with the EFY community. Enjoy the race.
Thank you. And Carol, I want to thank you so much. This has just been such a joy to get to know you over this project, and I think we've just had so much fun. And Thank you for this green tea. I think we should cheers.
Okay.
Cheers to this, and cheers to screening prevention and wellness to all our watchers out there. And we just thank you for tuning in.